Good evening, ladies and gentlemen. Welcome to the International Bi-Monthly Webinar series called Learn from the Legends, organized by National Neonatology Forum Kerala and Indian Academy of Pediatrics Neonatology Chapter. Today, we have an eminent speaker, Professor Philip T. Levy from the Boston's Children's Hospital, USA, who will enlighten us on hemodynamic concerns in high-risk neonates. He will deal with HIE, infant or diabetic mothers, and PDA. To moderate this session, we have a couple of renowned neonatologists, Dr. Narmal Soni from Qatar and Dr. Samir Sheikh from India. So enjoy the academic feast. Now I hand over to Dr. V.C. Manoj to take over the proceedings from now.
Hello everyone, welcome. Today I have the honor to introduce yet another legend. He is a hemodynamics man. Professor Philip Levy is a physician in medicine at Boston Children's Hospital, attached to the Department of Pediatrics at Harvard Medical School. Professor Levy's patient-oriented and translational research initiatives focus on cardiac mechanics in congenital acquired cardiopulmonary diseases. His work is part of an international collaborative that was established to examine emerging non-invasive measures of cardiac function and pulmonary hemodynamics in large preterm birth cohorts to define physiological and pathologic patterns of postnatal cardiac adaptation. Today, he is going to explore how neonatal cardiovascular development plays an important role with common hemodynamic conditions including neonatal encephalopathy, infants or diabetic mother, and PDA. Friends, we have all listened to Philip Levy in the past, and we all love some of his original works like the algorithm for the management of PPHN. Now let's listen to the legend on another area which we don't really give much thought to in our day-to-day neonatal practice. Professor Levy.
Thank you so much for that introduction and a warm welcome to so many people from around the world. I know it's day, it's night, it's light, it's dark, and I really appreciate people taking the time to spend with me. What I'm going to try and do is, of course, I'll talk a little bit about different diseases in neonatology, but I want to go back to some of the basics. And I'm going to be very repetitive because as we learn to manage these children who have hemodynamic concerns, it's not only about echocardiography or NIRS or advanced imaging techniques. These basics physiology will help you understand how to manage these children from a clinical perspective. So the learning objectives today are threefold. I want to discuss the determinants of cardiovascular mechanics. Specifically, I want to understand what makes the preterm heart unique. Then I'll talk a little bit about emerging approaches to characterize cardiac mechanics. And of course, answer many of your questions in the chat about how to integrate this into your own clinical practice. And finally, we'll talk about different hemodynamic applications as they relate to different neonatal diseases. So this is really the premise. So if we think about early events on cardiovascular outcomes, you can see on the y-axis, we have cardiovascular endowment. And over time, from the fetal stage to the adult stage, you have normal cardiovascular developmental aging. But there could be a primary insult. It could be genetic. It could be environmental. It could be placental. It could be epigenetic. It could even be prematurity. And what that will do is alter the course and lead to a decreased endowment and increase the susceptibility of secondary insults. So not all of these individuals will be at harm, but it's when you have further insults. So hypoxia, hemodynamic changes, infections, nutrition, all of that will unmask what I call clinical phenotypes in cardiovascular outcomes. But before you can learn to treat these outcomes, you need to understand the neonatal myocardial mechanics. What happens in embryology? What does the morphology look like? What's happening at the cellular level? What happens with performance, afterload, preload? How does this affect metabolism? And finally, how does this affect vascular tone? So we'll start off with embryology, and I love the history, and it's important for everyone to understand this. The cardiovascular system actually was first described by Hippocrates back in 400. He hypothesized that it was an open-air system. Blood came from the liver, it went to the heart, and the heart magically turned the blood into air, and air went to nourish the entire body. We know that that is not the way of thinking, and Galen actually said that there were invisible pores between the right side and the left side of the heart, where blood goes from the liver to the right side, doesn't really go through the lungs, skips the lungs, goes to the left side and supplies the body. And this way of thinking, while it's wrong, persisted for 1,500 years during the Dark Ages. It was only with really the Islamic Golden Age that finally kind of unmasked some of this. And it was William Harvey, who's the father of cardiovascular physiology, said, no. Blood comes from the liver, goes to the right side, goes through the lungs, goes back to the left side, and feeds the entire body. And this is what we call a closed vascular system. So this progression of hemodynamic care mirrors what we've seen even over the last 100 years. The way we used to do things are no longer the way we are going to do them going forward. So embryology is fascinating. Every neonatologist knows the way that airway develops from the embryonic stage all the way to the alveolar stage. But cardiac morphogenesis actually precedes airway development. And the vasculature arises from a temporal and spatially controlled process linked between airway and between cardiac growth. So translating that into, for example, pulmonary hypertension, you know that there could be a problem with the lungs. There could be a problem with the heart, but it's that connection between the heart and the lungs, how they're coupled, how the vasculature develops, that helps you manage and determine long-term outcomes. And it all goes back to embryology. I love genetics, and it's important to understand that there are key regulators as the heart twists and turns and becomes each of the outflow tracts and the ventricles and the atria. There are genetic regulators that are modulating this. So with congenital heart disease, for example, hypoplastic left heart syndrome, some of these modulators are abnormal. What we've learned over time is that the right ventricle is connected to the pulmonary circulation in one field, and the left ventricle is connected to the systemic circulation in another field. And all of that goes back to genetic underpinnings. When we talk about morphology, we often talk about the layers of the heart, the location, the chamber structure, and the fiber orientation. And I'll give you a very high-level overview that will help you understand how we use emerging techniques in neonatology to assess cardiac performance. So we know that the right side is not the same as the left side, and an adult heart is not the same as a neonatal heart. For example, an adult heart is about 30% water, and a neonatal heart is 70% water. So this is a nice graph that shows you that the size of the weight of our preterm hearts at 25 weeks is 4 grams, which is the weight of about 1 US coin, all the way up to 20 grams at 40 weeks, which is the weight of a protective N95. And you can see that when we are dealing with a 25-weeker, we're dealing with such a small heart with small features. What I love about this is it really compares the weights of an adult heart to the weights of a preterm heart. The adult female heart weighs about half of a soccer ball or football, if you like Manchester United. The adult male heart weighs about the size of a proper job or an alcoholic beverage. The term heart weighs the weight of a Duracell, and the preterm heart weighs about 1 British coin. So that gives you a real gamut of what we are dealing with. Now for some fibers. This may be a new concept for people, but I want you all to understand that there are differences between the left and the right side. There is a fiber pattern that wraps around both the right and left side of the heart that dictates its performance. Underneath the top layer is a bottom layer that again wraps around the top and bottom part of both the left and the right ventricle. Underneath that is what we call the shared longitudinal pattern, which again wraps around both the right and the left side. And finally, there is a circumferential pattern that only wraps around the left side. So when we put this all together, you can see that the right side has two unique patterns, and the left side has three unique patterns. Why is this important? Well, the left side is circular. It has a circumferential pattern that really provides 60% of the ejection and the stroke volume, while the right ventricle relies on longitudinal patterns. And this dictates how we're able to use echocardiography to assess overall performance. So what you have here in the next kind of slide is we're going to look at some of the cellular functions. And this is going to help you understand why we choose some of the medications that we choose in different cardiovascular compromises. So in the preterm heart, it's fascinating. This is electron microscopy from animal models, but the preterm heart has less myofibrils and has less mitochondrial. So there is just an overall decrease in the energy and metabolism capacity compared to the term hearts. Let's look at a picture of this. You can see with the preterm heart that the sarcoplasmic reticulum are underdeveloped. The nuclei are larger. There are no transverse tubules, which really help with calcium metabolism and linking the sarcoplasmic reticulum to the sarcolemma. We take that a step farther, and this picture comes from my good friend Afif El-Kufash with calcium metabolism. Again, very high level, what we know is that you have extracellular calcium. The white dots go through L-type channels into the cell. That activates the release of large amounts of intracellular. So you have calcium-induced calcium release inside, from outside to inside. And then you have contractility of the myofilament. And all of this is facilitated by the L-type channels and T-tubules. So again, if this is new for everybody, the take-home message is that in the preterm infants, there are less L-type channels and less T-tubules. So the overall ability to enhance contractility in a preterm heart is significantly decreased. We know that calcium function helps with muscle contraction, cardiac development, conductive system, housekeeping functions. But if the immaturity of the sarcoplasmic reticulum exists, all of these functional aspects will be underdeveloped. Here is a real-world example. Many people use the medication milrinone for two reasons. It helps with contractility and increasing stroke volume by blocking the phosphodiesterase 3 receptors in the cardiac muscle cell. And in the smooth muscle cell, we know that it will block the phosphodiesterase 3 receptors and lead to a decrease in SVR, an increase in pulmonary vasodilation. But in the preterm infant with an immature sarcoplasmic reticulum, it's a little unclear how milrinone will be impacted. Will it cause more harm or less harm based on the receptor physiology? Next, I want to talk about metabolism. I want all of you to think about the time that you've been in the delivery room and the baby doesn't breathe for the first minute of age. And the first gas is, say, 6.9 with a CO2 that's really elevated and evidence of metabolic acidosis. And you think to yourself, there's no way that this baby is going to be able to survive. But for some reason, babies tolerate hypoxia and acidosis better than any other living human being. And let me show you why. Now, the preterm infants rely heavily on glucose. They don't rely on fatty acids and they don't rely on beta oxygenation. They tolerate acidosis. They don't have a high oxygen consumption and they tolerate hypoxia. Now, a nice study by my friend Shahab Nouri almost 10 years ago looked at different levels of pH on the x-axis in figure A and figure B, and then looked at measures of function, shortening fraction in figure A on the y-axis and contractility in figure B on the y-axis, and showed that irrespective of the varying degrees of the pH, the function and the contractility remain preserved. So that gives us real insight to that these preterm babies can tolerate the hypoxia and the acidosis extremely well. Let's go into performance. And this is really the crux of the talk, to understand and then translate into your real world practice. I want to take everyone back to the basics. The components of the cardiovascular system beyond the circular system are threefold. You have the heart that acts as the pump. You have the vasculature or the transport network bringing the blood or the transport vehicle to the pulmonary system and the systemic circulation. And the goal is cellular homeostasis. It's a balance between oxygen consumption and oxygen delivery. So let's look at that a little more closely. When we think about cellular metabolism, it's not just blood pressure. It's a balance between cardiac output, the heart, the target organ, or the brain or the lungs, I'll give an example, and then the oxygen delivery and oxygen consumption. But cardiac output is determined directly between three key elements. Preload, how much blood is going into the heart. Afterload, how much resistance the heart is facing. And contractility, the intrinsic ability of the heart to contract. Contractility is not function. Preload, afterload, and contractility determine the overall function of the heart. So let me give you an example. Here we have hypoxic ischemic encephalopathy, where the target organ is the brain. The cardiac output comes from the left ventricle, and what determines all of that is the relationship between preload, afterload, and contractility. And I'll give an example towards the end. The next example is persistent pulmonary hypertension of the newborn. The target organ is the lungs or the pulmonary vasculature. The heart component is the right ventricle, and we need to balance the afterload, preload, and contractility of the right ventricle to help improve overall status. So that gives you an understanding of the relationship between preload, afterload, and contractility. But it's important to understand where this comes into play with preterm infants. But more importantly, it's important to understand how contractility patterns of the heart determine the overall performance. So I mentioned before that the right side has two fibers that dictate all of the contractility. On the right, it's the deep longitudinal is the primary, and on the left, it's the circumferential. So let me show you some examples. Here is an echocardiogram of the four-chamber heart, and you can clearly see that the right ventricle has longitudinal fibers that are pulling the tricuspid valve up and down to enhance contractility and stroke volume and cardiac output. There's also an inward movement of the free wall, and there's also a connection of the right ventricle to the left ventricle. The translation to the clinical practice, if you have a baby who is having right heart failure, you need to make sure that it's not due to the left heart. Is it due to the pressures in the lungs? Is it due to the fact that you're not giving enough fluid to resuscitate the baby? So that gives you insight in how to manage the right side. What about the left side? Well, we know that the left side has three patterns. There are circumferential patterns where you can see the twist, the relaxation, the in and the out, and this is driving the cardiac output. There is longitudinal patterns, and there are rotational patterns. That is the twisting and the relaxation of the heart. So the right ventricle is simplistic compared to the left ventricle. So again, this is new for a lot of people, but it's important to understand that as we develop tools to assess cardiac function, you need to understand that morphology dictates function. In the neonatal myocardium, we have learned over time from animal studies that preterm infants have higher collagen to protein ratios on the y-axis in figure A. Term lambs have minimal collagen deposition compared to the preterm lambs that can have severe fibrosis compared between figure B and figure C. What that tells us overall is that the neonatal myocardium, specifically the preterm myocardium, has a decreased contractile state. It's prone to diastolic dysfunction. You ask the question, why does a preterm baby, why are they at risk for pulmonary hemorrhage after being born? Well, guess what? Some of the theory of pulmonary hemorrhage is that there is a backup of blood from the left atrium through the pulmonary veins into the pulmonary vasculature that causes the pulmonary hemorrhage. Well, the preterm infant has diastolic dysfunction and abnormal contractility. So if the preterm infant can't pump the blood forward through the left ventricle out to the body, it will go backwards, left atrium, high pressure in the pulmonary venous system, and pulmonary hemorrhage. So that's your clinical real world experience. The preterm myocardium with preload and afterload is very fascinating. We know from the Frank-Starling curve, the higher the preload, so as you put more preload in that left atrium, you will increase your stroke volume to a point. The immature heart is limited, and immature hearts cannot increase their stroke volume or cardiac output. Similarly with afterload, as you go up on your afterload on the x-axis, well, you'll augment more stroke volume, but the immature or the preterm heart can only do that to an extent. So again, I'm showing you that preterm infants have altered loading conditions on top of contractility issues. The final piece of the puzzle before I spend time on real-world clinical examples is the vascular system. It's the often forgotten piece of the puzzle. So what do I mean by that? It's very interesting. The parasympathetic system is fully formed after birth. The sympathetic innervation is incomplete and is even more incomplete in the preterm population. So what does that translate into real-world experience? If you have a baby who has low blood pressures and you want to start them on dopamine to increase their SVR or epinephrine to increase their SVR and increase their afterload in order to augment their function and cardiac output, well, guess what? In the preterm infant, they may not respond as well because what I'm showing you here is that they have a decreased sympathetic innervation and they've altered alpha and beta 1 receptors. It's not to say you shouldn't try these medications, but my algorithm that I've developed is to have cutoff and thresholds. You should not just keep marching up the medications if they have no effect. They have no effect because the receptors in premature infants are not developed to handle it. So when I put this all together in a nice picture, I have shown you up to this point that there are cellular changes over time from the embryonic stage to the adults. There are calcium patterns that changes. There are changes in cell division and cell size. I've shown you that there are changes in metabolism with the ability to tolerate acidosis and hypoxia. And I've shown you that there are changes in performance with contractility and loading conditions. And when you pull back the curtain, you can see that the preterm infant looks like the adult who is in a diseased state. But we know that the preterm infant is not diseased. It's just under development that will catch up over time. So I want to be able to look at some of the novel measures that we've explored to assess cardiac mechanics. And then I want to take a dive into some of these different disease states. So when we talk about novel measures, we talk about echocardiography and cardiac catheterization and cardiac CT and cardiac MRI. I recognize that throughout the world, you don't have all of these modalities. And I teach this, but I teach them that they are complementary to clinical exam, vital signs, and biomarkers. And you can very succinctly manage babies without all of the fancy tools. But if you understand the hemodynamics of what I just spoke about, it will enhance your clinical exam and will tell you when to obtain the advanced imaging. So when I think about the heart, I think about it with the assessment of kind of 3 features. This is for echocardiography. I think about the heart as relaxing and contracting with a change in what we call cavity dimensions. And you can see this very nice figure from diastole to systole. Everything is from diastole to systole. We can look at the difference in those. And those are measures like ejection fraction and fractional area of change. So that's one approach. The next approach is you can look at a single point on the echocardiogram from diastole to systole, and that change will give you insight into how the heart is functioning. So that's things like tissue Doppler imaging and TAPSE. Again, this is very high level stuff. And some of the newer modalities look at the deformation of the heart tissue from a baseline shape in diastole to a new shape in systole. So again, it's really just looking at changes from diastole to systole to give you an assessment of cardiac function. Now, this is done with advanced imaging. So again, people always ask me, Dr. Levy, how do you know what measures to choose? I just go back to the basics. The assessment of cardiac performance is based on preload, afterload, contractility, and morphology. This is what dictates the overall health. So all of the measures that we have assessed over time, that legends in the field like Patrick McNamara, Afifel Kufash, and Amish Jain, we have spent the last decade looking at all of these measures. I'm not asking for people to memorize the measures. I'm asking for people to understand what the measures are looking at. They're looking at measures of afterload, contractility, and preload. And what we have done succinctly over time is we have published these algorithms. So this is a paper from 2019 looking at pulmonary hypertension. We've looked at measures of RV function. We've looked at diastolic function. We've looked at RV afterload. We've looked at RV morphology, and we've published all of this. Not one measure is better than another measure. The measures complement each other, but it's important to understand how we got these measures, not just to use the measures. And what I've given you up to now is the assessment and the physiology behind the use of the measures. Again, just so everybody knows, each measure has been validated. We're showing that there are mechanistic approaches, that there are normal patterns, and that we are now using these measures in therapeutic models. We are using these measures as outcomes, meaning we're doing Z-scores. We're using them to assess pulmonary hypertension. It's no longer just the TR jet or septal wall flattening. Our measures over time are more sensitive and more specific. And again, my colleague and I, Afif Al-Kufash, have really spent the better part of a decade looking at all of the different measures on the screen, looking at measures of afterload, performance, and LV performance. And I refer everyone to a great article that's now almost 6 years of age if you want to spend more time looking at these measures. So let's just use one example. So the strain is what I talked about. It basically is a very sensitive measure of function. It tells you about the change in shape and gives you insight, almost like the HbA1c would for diabetes. This gives you insight into the function over a long period of time. And what we did over the course of 10 years is we looked at feasibility and reproducibility. We looked at technical features. We looked at inter-vendor comparisons, all to enhance the feasibility. We looked at maturational patterns. We looked at maturational patterns in preterm infants. And finally, we looked at Z-scores and implementing them in real-life clinical scenarios. And this, for those interested in research, this is the systematic approach to taking an idea from the bench to the bedside. So I want to shift for the last 15, 20 minutes about health and disease. And I anticipate that there will be many questions in the Q&A and the chat portion on these topics. So the first thing we did a long time ago is we looked at natural patterns, and this is an example of the right side of the heart. What happens with the right ventricle over time? We learned in the fetal stage that the function actually goes down as the PVR goes up. And when the healthy term infants are born, the PVR drops, and right ventricle function, as assessed on the y-axis in figure B as a strain measurement, free wall longitudinal strain, it improves. So we took this maturational pattern in term infants, and we looked at the maturational patterns in preterm infants. And what we found was fantastic. We found that all preterm infants regardless of their lung health, regardless if they had BPD or they were on oxygen support, had worse RV function over the first year of age compared to the term infants. Now, of course, if you had BPD or pulmonary hypertension, your RV function was worse as it responded to increases in pulmonary artery pressures. Now, we looked at the left side of the heart, and initially we found no differences, which didn't make sense to us. But again, we were only looking at one aspect of that three-pronged morphology approach that I spoke about. But you can't just look at the longitudinal measures. You needed to look at the way the heart twisted, and you needed to look at the way the heart relaxed. And what we found was that the left ventricle over time was impacted at 32 and 36 weeks, but the left ventricle recovered over time. So again, using these advanced metrics, it allowed us to give us clinical insight into why babies may have systemic hypertension, why their left heart may fail and recover. This is insight that we brought from the bench to the bedside. What we did with the preterm population, which is really phenomenal, and if anybody ever wants to study the effects of former individuals born preterm, this study looks at it. Basically, we tracked through meta-analyses preterm infants from birth through adulthood. And what we found is that irrespective of your lung disease or your neonatal complications, all preterm born individuals over time have altered RV function, altered LV function, decreases and changes in morphology. And it gives us a real sense of the phenotype that is evolving in these individuals. They clinically look like everybody else, but it's these individuals that if they were to get asthma or COVID, for example, their heart function can be greatly affected over time. And what we did with the meta-analysis is we looked at all those measures that I had mentioned, and we clearly, distinctly showed using forest plots that all of the measures favored the term-born individuals from birth through adulthood. This is an example of RV strain. Again, if anybody's interested in meta-analysis work, this is a great way to get into the field. So over time, this is what all of our research has pointed. There are unique features of the preterm heart. I talked about contractility. I talked about loading conditions. I talked about unique autonomic responses. We know that in the critical development window in the first year of age, there are changes in the right and the left ventricle. There are changes in morphology. These persist to the adult cardiovascular phenotype, and the ultimate consequences is seen with heart failure, pulmonary hypertension, ischemic heart disease, systemic hypertension. And if you don't understand the background, the morphology, the mechanisms, the metabolism, you can't understand how to treat these individuals born preterm. Now, taking these concepts forward, the question always becomes, how can we alter the trajectory? Are there things that we can do in the neonatal period to alter cardiovascular performance? So we did a nice study where we looked at preterm infants who were fed breast milk. And we wanted to see, is there a correlation between how much breast milk you get in the preterm period and the cardiac function over time? And what we actually looked at is all those measures of afterload and performance and left side and right side to assess as our outcomes. And what we clearly showed is that the more breast milk you got, and this can be done anywhere in the world, you don't need echocardiography to give breast milk, but the more mother's own breast milk a preterm infant got, the better their long-term right and left ventricular function was. We showed that for 28 days, 1 month of mother's own milk enhanced your overall function to almost normal in the preterm infants compared to the term infants. And when you look at this figure, comparing the term controls in green, you can clearly see that those individuals in orange who received high mom's own milk, MOM, compared to the low breast milk, had enhanced function over time. And we looked at a lot of these mechanisms. We wanted to understand, why is this so? We think that there could be a component of VEGF, a component of stem cells, HMOs, immune factors. All of this are theories that can help alter the cardiovascular phenotypes of prematurity and lead to improved outcomes over time. This is a simple intervention that can be done at the bedside. So when I think about the hemodynamic applications that I just spoke about, I think about cardiovascular diseases. I think about right heart disease and left heart disease. I think about things like CDH, vein of Galen, AV malformations, HIE, Down syndrome. I think about pulmonary hypertension and necrotizing enterocolitis and extreme prematurity and the ductus. And I think, how can I take the tools that I just spoke about and apply it to each of these diseases? So I will spend the last 5 minutes really dissecting the mechanisms and applying it to the disease state. So let's look first at the ductus arteriosus. Many of you are very familiar with this. When I think about the duct, I think about hemodynamic significance. I think about the balance between the lungs and the systemic circulation, or the shunt volume. I think about how the heart adapts. Are there changes in the left ventricle? I think about the function of the heart. Is it increased or decreased? And I think about comorbidities. What is NEC, IVH, AKI, acute kidney injury? And that's how I decide if I want to augment closure of the PDA. Now, we all know that when you're beyond the point where you want to augment closure, it all goes back to preload and afterload. So here is a nice picture where blood is leaving the left ventricle and going into the lungs, left to right, systemic to pulmonary shunt, and you have all the blood coming back into the left atrium. So the preload is high and less blood goes out to the body. So the afterload is low because the body lowers its diastolic blood pressure because it wants more of the blood. It's not fair that the lungs get everything. Then you go for definitive closure. You can do a PDA ligation in America, in North America, in Europe. They are doing device closures of the PDA. It's an abrupt closure. And all the blood that was going into the lungs, well, guess what? It's not going into the lungs anymore. So it's not coming back to the left atrium. So the preload goes down. There's less blood there. Now, all of that blood that was going into the lungs, where is it going? It's going to the body. It's a rush to the body. The body cannot handle it. The body puts up its defenses, and the way that the body does that, it increases your SVR, it increases your diastolic blood pressure, and what happens is some babies do okay, and some babies fail. And I just told you why. Some babies do not respond well to changing and loading conditions, and some babies have immature preterm myocardial responses. So when we talk about the PDA, we talk about an entity called post-ligation syndrome, where before the baby was ligated, their X-ray looked clear. But 6 to 12 hours later, the heart has failed. It can't tolerate the decrease in preload, and it can't tolerate the increase in afterload. So the blood doesn't leave the left heart. It actually backs up into the left atrium. It backs up into the pulmonary venous circulation and backs up into the lungs. And overall, you have more FiO2, worse ventilation, higher mean airway pressure, and you get this entity of post-ligation syndrome. You have an immature contractile system. You're poorly tolerant to changes in loading conditions. And because of that Frank-Starling condition, you have diastolic dysfunction. And there are many risk factors that I won't go into it, but basically you need to understand that with the PDA, it all goes back to preterm myocardial response. And it goes with oxygen failure, ventilation failure, and changes to the systemic hypoperfusion. Now, this is transient. It resolves in 18 to 24 hours, but you need to be able to recognize it. Now I'm going to shift a little bit to infants of Down syndrome. So over the last 20 years, it was a real belief that if you were born with Down syndrome and congenital heart disease, you are at risk to develop pulmonary hypertension. But if you didn't have congenital heart disease, your risk of pulmonary hypertension and pulmonary vascular disease was much less. Well, that has been debunked. That's not a true statement anymore. Up to 30% of infants with Down syndrome can be born and are at risk to develop pulmonary hypertension acutely in the early period or in the chronic period. They have chronic changes from their placenta, which affects their pulmonary vasculature. And really nice work out of Colorado and Ireland has really shown this. What they have shown over time is that compared to controls, highlighted in blue, you can see in figure A and figure B, where you have RV and LV systolic function on the y-axis respectively, that over the first 2 years of age, you can clearly see that infants with Down syndrome have worse LV and worse RV systolic function. We've been able to unlock this with the advanced hemodynamic metrics that I spoke about. We shift to neck. Now, neck is fascinating. If anybody has treated babies with neck, it always remains a mystery. I'm not here to tell you what causes neck or how antibiotics or probiotics or human milk or medications or primary infections or anemia or transfusion or chorioamnionitis, how all of that can impact neck. What I'm here to tell you is about the hemodynamics. And in order to understand the hemodynamics of neck, it all goes back to understanding afterload, preload, and contractility, where oftentimes you're left with a premature baby who has an elevated heart rate, and you think it could be sepsis or pain or arrhythmia or even a hydration issue. But to me, when you have ventricular dysfunction, you need to ask yourself, what is the issue? Is it a preload issue? Is it a contractility issue? Is it an afterload issue? Is it due to altered coupling mechanisms? Is there sepsis physiology? And that will guide you on how to treat. So if you have a problem with preload, if you're under resuscitated, you give preload, you give volume. If you have a problem with function, contractility, you give a medication that will alter the function and enhance it. And if you have an issue with high afterload, so sepsis physiology, but preserve function, then you may want to give a medication to reduce the afterload. It all goes back to preload, contractility, and afterload. HIE is fascinating. There are many different stages, but we know that there's an insult, and then there is the reperfusion state. So when in the insult state, I want everybody to really stop and think about it. There's an insult to the brain. We often see an insult to the liver. We see an insult to the coagulopathy. But guess what? We may actually see an insult to the heart and to the lungs. And how we manage this during the hypothermia and rewarming is really invaluable. So again, it goes back to afterload, preload, and contractility. So if you have a hit to the heart, there could be a primary hit to the left ventricle, a primary hit to the right ventricle, but you could also have hypoxia and acidosis that causes pulmonary vasoconstriction that leads to a pulmonary hypertension physiology with the impact on the right heart and the coupling mechanism. But what we know is that when we have hypoxia and ischemia, we get changes in low cardiac output because you have alterations in your left ventricle. You have less blood going into the lungs, less blood coming back to the body, and you can end up with cerebral autodysregulation. What we do is we lower the temperature and we do hypothermia in order to preserve the energy and the metabolism. And the problem is that can actually increase your SVR. It can reduce preload, reduce heart rate, and increase blood viscosity. So it's a tricky balance between the management of the HIE and the pulmonary hypertension. So CDH is something that has always fascinated me. We know it's a defect in the diaphragm. We know there could be pulmonary hypoplasia. We know that there could be pulmonary vascular disease. And we know that there could be cardiac dysfunction. The reason I mention CDH is because of understanding the algorithm of how it plays with pulmonary hypertension. We know that it could be a maldeveloped system, right? It could be either a primary insult from the lungs, or it could be a secondary insult from the bowel affecting the lungs. It could be an issue with high acid levels and hypoxia and affect CDH in the lungs. And then we also know that it could affect the left heart and cause left heart disease, all leading to the causes of pulmonary hypertension, either by the vasculature or the left heart disease. But when you stop and think about the beginning of my talk, I talked about the diaphragm, I talked about the development. Well, guess what? The diaphragm also develops at the same time as the airway, the vascular development, and the cardiac development. So when you think about this over time, you can understand that there are definitely genetic regulators that are occurring during the embryonic stage. But really what I want to highlight is this, is that you will have evidence of RV changes, evidence of LV hypoplasia, and then after birth with a congenital diaphragmatic hernia, you have elevated PVR, elevated SVR. Over time, the LV will recover, but it's the RV that will actually remain sick. And the RV, if not treated properly, is what is going to dictate your long-term outcomes. So there are techniques all over the world that try and limit hypoxemia and sepsis and sedation and your mean airway pressure, all to promote recovery of the right ventricle. So when I think about the hemodynamics of CDH, I think about it with this paradigm. As you go up on your pulmonary vascular resistance, okay, that's afterload, RV performance or contractility will meet its demand. Essentially, you access your functional reserve, you have a peak RV function, but the problem is that if the RV afterload keeps going up, the RV performance will ultimately fail. And you need to start to think of the management of all of these children in 3 phases. How is my function meeting my afterload? And it's not necessarily a good thing if my function is hyperdynamic, because if the afterload continues to rise, as is shown in stage 3, ultimately the RV will dilate, hypertrophy, and can't match the demand, will uncouple, and will fail. So this is a very nice summary slide of how I approach the management of cardiovascular dysfunction with thinking about preload, contractility, and afterload. And I put this picture on the screen for people to be able to take a picture of it and understand that when I think about the management of different disease states, and this is for pulmonary hypertension, I think about what are my goals. In pulmonary hypertension, the goal is to decrease PVR and decrease pulmonary artery pressure. The goal is to increase your SVR, to have more blood go from left to right to supply the pulmonary circulation. And the goal is to optimize heart function. As you look at each of the drugs that I've mentioned, you need to ask yourself, what are they doing? What are the effects? What are the effects on SVR? What are the effects on PVR? What are the effects on contractility and stroke volume? And I've listed them and highlighted them, but it's also important to understand the receptors. It's also important to understand cutoff values for when you would start one med and move to the next med. You don't want to max out everything without thinking about 3 steps down the line. So what I hope that I have shown you today, and thank you so much for having me, is that the cardiovascular development is a highly coordinated process that's linked to programmed structural, functional, and genetic mechanisms in term and preterm infants. The preterm cardiovascular system is underdeveloped and responds to changes in loading conditions, preload, afterload, contractility. And I think enhanced hemodynamic monitoring, along with hemodynamics and clinical examination, should be used in combination to serve as a catalyst for prospective physiology-based research. And with that, I just want to acknowledge the hosts and the organizers for this amazing conference, and also for all of my colleagues around the world. And I am extremely happy to answer any questions this morning, this afternoon, and this evening. Thank you.
Wow, that was truly an amazing lecture. I'm sure all of us had a very enlightening session. Now we have some interesting questions coming up. After a short video, we will go on to the panel discussion. Friends, now we have an interesting discussion coming up. I have great pleasure and honor to invite two leading neonatologists to moderate this session. May I invite Dr. N.B. Soni, consultant neonatologist from Qatar, who is also an authority on neonatal hemodynamics, to moderate this session. May I also invite Dr. Samir Sheikh, consultant neonatologist from India, to moderate this session. May I request both of you to kindly enable your videos. Over to you, Dr. Soni.
Thank you very much, Manoj. And thanks, Professor Levy, for a very enlightened presentation, covering a wide range of things in your talk, from the basics of the development of the heart, having the understanding of different fibers, the cellular metabolism, and how does a preterm response differently to a term baby when put to a stress, how the innervation is immature as well, and then going on to the assessment of the heart in a very systematic boxes of thinking, whether it is to do with the preload or afterload or a pump itself, and then going through the different disease states and different clinical states, how the various hemodynamic issues can develop. And looking into the health and disease, even though it's a very intensive topic about the hemodynamics, you did not leave about the breast milk importance and raising the awareness that how it makes the adaptations to the preterm myocardium much better. So thank you very much for a very, very enlightening talk. I learned a lot from this. And I'm sure our audience enjoyed. There have been lots and lots of positive remarks already I saw in the chat box. So I'll start off with some questions, but before that, I would just invite some comments from Shamir Sheikh, my colleague moderator. and then we will start with the questions. Samir, do you have any initial remarks to make before we go on to questions?
No, sir, couldn't agree more with whatever you said. It is pretty lucid presentation. I beg your pardon, but I was intermittently present because I was busy with an emergency. But I've never heard anyone who is so lucidly talking about the interaction of inotropes and the heart function. So that was very, very, very clear, especially for the fellows and the practicing pediatricians. Once again, thanks a lot, Philip sir, for doing this for all of us. Thank you, sir. Over to Sony, sir. We'll start with the question answer, sir.
Sure. So, Prof. Philip, the most questions are relating around the use of inotropes. And in fact, most delegates are asking if there is a very simplified way of telling which inotrope to be used for which particular condition, or for a gestation like a preterm versus term, or different disease states, which inotrope would you use? So do you have any remarks on that front to start with, and then we'll build on more questions related to the inotropes?
Sure, that's a great question. And what I did is I put up this diagram, which I'm happy to share with everybody offline. So I think it matters what different disease states that you're dealing with. So I'll give a few examples of the different disease states, and that will help people understand. So let's start with the simplest one that we all care for. So if you have a baby who has clinically persistent pulmonary hypertension of the newborn and is having significant hypoxemia and hypoxia, let's say the baby is a term baby who had meconium aspiration, what would you normally do? You would approach that baby in a systematic way. Well, the first thing you're doing is going to optimize ventilation and oxygenation. The next thing you're going to do is optimize the sedation, sometimes even muscle relaxation to decrease metabolic demand. The next thing you're going to do is treat any infection, because infection can cause acidosis, which can cause further increase in pulmonary vascular resistance. The next thing you're going to do is you're going to correct the electrolyte. So if it's a hypoglycemia baby or low calcium or altered acidosis, you're going to correct that. And then once you've done all of that, if the baby is having low blood pressures, however you define that, and you can get an echocardiogram, you or cannot, you're going to ask yourself, is the low blood pressure, is the low cardiac output due to a contractility issue? Is it due to a preload issue? Is it due to an afterload issue? So the simplest thing to do, which is probably the least harmful, is to address the preload. So we often give some type of fluid resuscitation, either normal saline. If it's appropriate, let's say in placental abruption, you may give packed red blood cells. Then if you have the ability to get an echocardiogram, you could then look at the function of the heart. If the function of the heart is preserved, then it's very possible that you don't need an inotropic, or I'll call it a cardiotropic medication that is needed to enhance contractility. You need a medication to increase your afterload or increase your SVR. So if you look at the list of medications that I've put up there, you can see that the medications that increase SVR are things like norepinephrine, epinephrine, hydrocortisone, or dopamine. So let's just say, for example, in your institution, you like to use dopamine. Let's say there is a little heart dysfunction. Well, dopamine, if you can clearly see down that bottom line, increases your SVR, and it also increases your contractility. That's a good thing. But what doesn't it do? In pulmonary hypertension, it doesn't decrease your pulmonary artery pressure. It actually increases it. So most of these medications do two of the three desired effects. Now, I'll follow through with the dopamine example. And that's not actually my first line. My first line in a baby who has issues with contractility and issues with afterload would be probably a little epinephrine. But I would start the baby on epinephrine, and I would bring the titrated up. I would not go higher. You can see at the bottom there, there's a cutoff value. I wouldn't go higher than 0.1. Once you go to that dose, you're saturating the receptors. You have to think about a secondary agent. So if you feel that there's still evidence of pulmonary hypertension and the PVR is still high and you want to add in another agent, but your blood pressure maybe is well supported, you may think potentially about milrinone, or you may think potentially about vasopressin in those situations. The point I'm making is it's hard to give people exact advice on which medication to use and when to use it. What you need to do is every time you start a medication, do I want to increase PVR? Do I want to increase SVR? Do I want to increase contractility? At the same time, I'll give you an example. I've had practitioners put a baby on dopamine and epinephrine and dobutamine, and I then turn around and the heart rate is 205. Well, all of those medications increase your heart rate, which is shown in this figure here. You, in those situations, may want a medication that will increase SVR, but not increase your heart rate to such an extent. So that's where vasopressin may be more beneficial, or norepinephrine may be more beneficial. However, what I did on the side is you can see this really nice pearls. If you have, let's say, coarctation of the aorta, or LV dysfunction from HIE, if you give the baby vasopressin or norepinephrine, medications that increase SVR and lower PVR, but have no impact on contractility, you will make it impossible for the heart to eject blood. So you're actually doing more harm than good. So it's about understanding SVR, PVR, contractility. It's about understanding the underlying mechanism of injury. So for example, in HIE, babies with HIE who have moderate to severe HIE may have an insult on the left ventricle and on the right ventricle. They're hypoxic, they're acidotic, their pulmonary vasculature goes down, they get intubated, they are desaturated. The echocardiogram shows evidence of pulmonary hypertension, and the question is, what medications are you going to use to treat this baby? Well, you want a medication to augment cardiac function. So epinephrine does that, milrinone does that, but you got to be sure that if you're going to use milrinone, your blood pressure is stable. If you're going to use epinephrine, you want to make sure that your heart rate doesn't go too high, because if your heart rate goes too high, then there's no time to actually fill the heart. Now, jumping forward, you ask, what's an example of that? What if you have an infant of a diabetic mother? We all know that they can have septal wall hypertrophy. In an infant of a diabetic mother with septal wall hypertrophy that's so severe, they get left ventricle free wall hypertrophy, and they can get left ventricular outflow tract obstruction. So the reason that these babies are so hypotensive is because they don't have enough preload going out of their left atrium into the left ventricle and out to the systemic circulation, because there's outflow tract obstruction. So what people do is they'll give a fluid bolus, but then they'll start the baby on dopamine or epinephrine. And that's actually not necessarily the right drug, because now you've increased the heart rate and there's no time to fill. Some of these babies actually need a little preload and need a heart rate blocker medication like beta blocker or hydralazine or even esmolol, which we have used to lower the heart rate, to allow time to fill the heart, to control the diabetes, to allow the outflow traction to go down over time. So it goes back to understanding the mechanism of disease, the morphology that dictates the performance, and then interplaying that again on the major determinants of cardiac output, which again, I've said it again over and over, but it's preload, afterload, contractility, heart rate, and morphology. When you can understand all those features, I will sometimes pull out this chart on daily rounds and ask myself, what is my goal? I can't accomplish every goal with every drug, but I can use a combination of the drugs to get the goals. I hope that answers the question.
Sure, sir.
Fantastic, Professor Levy. On that note, that there is no single drug for giving as a mantra, but it is more about understanding the underlying pathophysiology and then going with the relevant drug. Thank you. Over to you, Samir.
Sir, just taking this thing forward about choice of inotropes. Sir, we have seen a lot many times in adult ICUs, people are using noradrenaline and adrenaline simultaneously. And simultaneously, many a time there is it was hypothesized that if you use noradrenaline instead of adrenaline, the coronary circulation is more preserved when you are using plain adrenaline versus noradrenaline. Sir, what's your take on this? Can we use noradrenaline and adrenaline simultaneously? Is there any criteria where we switch over from adrenaline, noradrenaline, or we should just put adrenaline to rest, tell him rip, and start using noradrenaline for preterm, term both?
No, that's a wonderful question. So a few caveats, and then I'll give some examples. So yes, the goal, and I've learned this a lot from my cardiac colleagues who manage babies with single ventricle physiology and congenital heart disease. It's very important to preserve diastolic function. Diastolic function and your diastolic blood pressure is what helps supply the coronary arteries. So that is a key component that not every neonatologist has a complete understanding of, and I've learned to appreciate it over time. So there is some nuance with the norepinephrine and different studies out there that will say it's better or worse for the diastolic function and the diastolic blood pressure. This is my general take on it. In sepsis physiology, if a baby is septic and you think that it's the warm shock where you are just vasodilated as opposed to the cold shock where you're vasoconstricted, which is, as most of us know, that's rare in neonates. But a baby who has sepsis physiology, who has warm shock, their diastolic blood pressure is really low. And remember, diastolic blood pressure reflects SVR. Systolic blood pressure reflects contractility. So your diastolic blood pressure is low. You don't need an echo to know that. Your SVR is low. And you have a choice of deciding between norepinephrine and epinephrine. Most of the times in sepsis, this is just the example, in the early phases, the contractility of the heart is relatively preserved. So that baby will need resuscitation with preload, and then will need a medication to increase your afterload. So norepinephrine from our pediatric colleagues has been shown to be more effective and has better long-term outcomes. So in that state, I would choose norepinephrine. Now the question becomes, when would I potentially switch between epinephrine and norepinephrine? Let's go back to our pulmonary hypertension state. Let's say initially a baby has hypoxia, hypoxemia, acidosis, and poor contractility. And the choice was made to start epinephrine. And we titrate up the epinephrine, and we start to notice that the heart rate is creeping up. The heart rate now is 160, 170, 180. Epinephrine, unfortunately, can cause some hyperglycemia. Epinephrine can cause through the metabolic pathways with lactic acidosis. And this is not the lactic acidosis we see with low cardiac output. But if you're on a situation where your heart rate is really high and your function appears to be maybe improved, and your blood pressure is not necessarily getting better, I might switch out the epinephrine for norepinephrine. Norepinephrine will decrease your PVR a little bit, really decrease your pulmonary pressure. It will increase your SVR more than it increases your PVR, actually. And it has very minimal effect on your heart rate. And it doesn't really have an effect on the glucose or lactic acid pathways. So that would be an example where I might make the switch between epinephrine and norepinephrine. Now, the caveat with norepinephrine, which I mentioned, and again, the group in Iowa has very extensively explored the use of vasopressin for the management of pulmonary hypertension. The challenge with pulmonary hypertension, we'll stick with that paradigm. We all know that pulmonary hypertension is increased mean pulmonary artery pressure. There are three factors that lead to mean pulmonary artery pressure going up. The first, number one, increased pulmonary vascular resistance. So that's acidosis, meconium aspiration, placental abruption. CDH can do it. The second feature is increased pulmonary blood flow. That's not common in the early neonatal period. We often think about that as PDA, left to right flow, but we have seen that with AV malformations, specifically vein of Galen, coronary artery fistulas. So if your pulmonary blood flow is high, that's the second issue. And the third issue is when you have left heart disease. If your left heart does not work, the blood backs up into your pulmonary venous system and can cause pulmonary hypertension. That left heart disease could also be manifested as infants of diabetic mothers, obstruction to the left ventricular outflow tract, or coarctation. Why do I give you all of these examples? If the pulmonary hypertension is due to pulmonary vascular resistance or pulmonary blood flow, then using a medication like norepinephrine to raise your SVR and have no impact on your heart rate, or vasopressin, which raises your SVR and lowers your PVR, that is great. But if you have a disease or a mechanism where you have outflow tract obstruction, coarctation, or infants of a diabetic mother, if you put them on norepinephrine, if you put them on vasopressin without a way to do contractility, you will end up leading the heart to fail as all the blood backs up into the lungs. So those are the pearls and caveats when we're thinking about which medication between norepinephrine and epinephrine.
Sir, what about the myth about noradrenaline preserving the coronary circulation better than epinephrine? And I would like your I would like your comment on the use of terlipressin also on any experience in neonates.
The use of vasopressin?
Terlipressin.
I'm not familiar with that. Which drug is that? What's the other name for that drug?
I'll find out, let you know, sir, that's generic one. But
it belongs to the family of vasopressin. It's the another generation within that.
Oh yes. Okay. So the data in the preterm and the neonatal population on noradrenaline and diastolic function is very all over the place. There is some older data from animal studies and the preterm population, very small studies that showed noradrenaline increases PVR, but increases SVR more. But it does have an impact on the dopamine receptors and the nitric oxide pathway to decrease your pulmonary artery pressure. Some more recent studies that have looked at the use of noradrenaline have not shown that same effect. Now, people have tried to study the impact on kind of the diastolic component and diastology, but just don't have the numbers to give a hardcore conclusion. I will tell you this. In the congenital heart disease world, where we can try and learn some parallels, people are very cautious with the use of norepinephrine or noradrenaline as they try and balance the diastolic component. People do, I agree with you, feel that it is more beneficial if you're trying to preserve the coronary artery flow. But there are other people that are skeptical. So it's not really the best answer to give you. In the neonatal population, don't particularly choose noradrenaline versus adrenaline or norepi versus epinephrine based on the impact that it's having on the diastolic function and my concern for coronaries. It is very rare to have a coronary issue in neonates with structurally normal hearts. The times that I've seen coronary issues are the unexplained hypoxic ischemic encephalopathy. Everybody on this call knows that when we deal with HIE, we're looking for a sentinel event: meconium, placental abruption, nuchal cord, abnormal biophysical profile. There are times where we don't find any of that. And the theory is that they had a coronary artery malperfusion. So in those cases, some people will initiate norepinephrine before epinephrine. But again, there's no data to support this. This all comes from anecdotal experience. In terms of the other family class of vasopressin, That has not been well studied to my knowledge, and it's not widely used, at least at Boston Children's. We use vasopressin. In terms of just a general sense, to answer the question, if we have a baby who's hypotensive, what we will do often is start epinephrine. We will titrate it up to about 0.1. So we started at 0.05. We'll go up by 0.01 to 0.1 mics per kilo per minute. If we feel we need to add a second line agent, the second line agent, obviously using the parameters I discussed, would be either dopamine or norepinephrine. At the same time, we add a second line agent. We often consider the use of stress dose steroids or hydrocortisone at 1 milligram per kilogram divided Q8 hours. This is because it takes 4 to 6 to 8 hours for the hydrocortisone to kick in, and there could be an adrenal issue. So for me, a second line agent is either the dopamine or the norepinephrine, or sometimes the vasopressin, and then we add the stress dose steroids. The third line agent will often be vasopressin. So it's not uncommon to see a baby on epinephrine, norepinephrine, vasopressin, and stress dose steroids, but you have to understand what you're trying to treat. And in those situations, those are children who are muscle relaxed and sedated with a low heart rate. Those are babies with severe contractility issues. And those are babies that are often septic with severe vasoplegia and dilated systemic vasculature. So that's kind of the approach. As you add a medication, you need to know the upper limit, and you need to know which medication you're going to add next. So what I tell everybody is, when you add your first medication, what are your parameters to add your second medication? And when would you think about adrenal insensitivity? And then when would you think about your third and fourth agents? And then when would you think about advanced imaging? So that's the approach that I try and teach people, rather than telling them to pick one drug over the other.
Thanks, Professor Levy. So just moving on with some different theme in the questions. There are a couple of questions related to the PDA. So when there is a low blood pressure because of the PDA or causing the shock itself, what the inotrope would you recommend is the one question. And then the second, in relation to that, because you work in Boston, and I'm aware that Boston uses the etiometry, which is the bedside evaluation of the other physiological parameters and their trends. So do you take that into consideration while you are making a bedside decision apart from the echocardiography? So how do you approach the PDA with the shock, blood pressure, low blood pressure management?
That's an excellent question. So the assumption is this is the PDA before you've augmented closure of the PDA. So as I mentioned, the blood, as it leaves the left ventricle, has a choice to go to the path of least resistance into the lungs or out to the body. And the majority of blood will go into the lungs, and less blood will go out to the body. So the body wants to receive more bloods, and the body will lower its resistance and lower the afterload, and you end up in a state of diastolic dysfunction. So oftentimes, if the baby is urinating, and if the baby is in a state of not shock, if the baby has a low acid level and the baby is well appearing, we do not necessarily manipulate the blood pressure. You have to understand that if you have a situation where there is low diastolic blood pressure, but every other parameter is stable and the function of the heart looks good, and there's no necessary evidence of intraventricular hemorrhage or necrotizing enterocolitis or acute kidney injury, if you raise the blood pressure, if you give a medication like dopamine or epinephrine or norepinephrine to raise your SVR, what you will end up doing is potentially putting more blood into the lungs and less blood out to the body. So unless I think that you're going to tell me the baby has a hemodynamically significant shunt, you're going to tell me that there is pulmonary overcirculation. The baby's up on the respiratory support. You're going to tell me that the preload is up and there are changes in the left atrium and the left ventricle. You're going to tell me that the baby may have some lower urine output and the creatinine could be a little bit bumped. The treatment is not to necessarily start a cardiotropic medication. The treatment is to augment closure of the PDA. So I'm hesitant to tell people use dopamine, use epinephrine, start stress dose steroids, because that will take you away from what needs to really be done, and that's to close the PDA. Now, we know that there are other maneuvers that can be used to help with the conservative approach. That's kind of limiting your total fluids, but to a point. You don't want to limit them too much, because remember, if you limit your total fluids into the systemic circulation, you're also limiting them into the lungs. Some people will use Lasix to treat the heart failure symptoms. I don't use Lasix. If I really think that there's heart failure symptoms, I'll use Diaril. Lasix has a theoretical impact on the prostaglandin pathway, and you'll give Lasix to diurese the baby, but that will excrete prostaglandins from the kidneys and keep the PDA open. Some people believe in shunt manipulation, where you can kind of find a way to increase your PVR so the blood doesn't go left to right on the ventilator. These are some of the conservative approaches. There's never been a randomized controlled trial to actually prove that any of these theories work. So going back to your original question, for this specific piece of the story, I try and understand what is the major problem. And the major problem is the duct is significant and open and it needs to close. Conversely, when I talk about definitive closure of the PDA, and I'll talk about etometry in a second, what I notice is that when I ligate the PDA or do device closure of the PDA, we do have these babies hooked up to etometry, which is just continuous heart rate, blood pressure, respiratory, ventilator management. What we have actually been able to see is a unique phenomenon. We know when you close the PDA, I mentioned it, but I'll mention it again. All the blood that was going into the lungs now is going to the body. The body will actually raise its blood pressure and you will have higher blood pressure. So you would think that if the baby started to have respiratory compromise because of the higher blood pressure, the higher diastolic blood pressure, the higher SVR, the blood can't leave the left ventricle, goes back into the left atrium, goes back into the lungs. You want to offload the left ventricle. So there are people who, that if the diastolic blood pressures are significantly high, will start prophylactic milrinone in order to enhance the contractility and reduce the afterload in SVR. Some centers like in Iowa and in Toronto will get an echocardiogram 1 hour after definitive closure. And if the cardiac output is low, that is indicative of higher SVR, and then they will start the milrinone. In Boston, what we actually do is we look at the respiratory support. We're able to look at the respiratory severity score, which is very simple. All of you could do it. It's mean airway pressure times FiO2. So if the mean airway pressure is 12 and the FiO2 is 50%, then the respiratory severity score is 6. What we showed is that if the respiratory severity score is higher than 4 at 1 hour after the procedure, you are more likely to go up on your respiratory support and you are more likely to end up on a different mode of ventilation. So what we do is we give a little sedation, we go up on the respiratory support, and occasionally we will start milrinone for a short period of time to offload that left ventricle. So the point I'm making with both of these scenarios is that we are able to use the continuous monitoring. We don't need echocardiography at the bedside in order to assess the hemodynamics, because we have the systolic and diastolic blood pressures, we have the information from the ventilator, and we have the overall clinical picture of the baby. We also know with the PDA, again, with closure of the PDA, it's a 6 to 12 hour phenomenon. The first 6 hours are a honeymoon. The baby looks great. At about 6 to 8 hours, the diastolic blood pressures rise more. It's an afterload issue. And that corresponds with clinical deterioration. It's not a preload issue. So putting this PDA story all together, you need to understand what you're trying to accomplish and where you are in each phase of the story. Understand that if the PDA is still open, and you have diastolic low blood pressures, you, rather than treating the blood pressures, because data has shown, at least early on, that yes, low blood pressures can lead to harm, but treating low blood pressures could also lead to harm, that you want to treat the issue at hand, which in this case would be augmenting closure of the PDA. So that's kind of a general broad stroke approach to the PDA from before to after closure.
Prof. Levy, just to end on the discussion on the PDA element of it, from your practice, the device closure versus the thoracotomy ligation, because when we do a thoracotomy ligation, you are closing the PDA in one go, whereas when you are putting a device closure, it still allows us some little bit of residual leak in the PDA over the next first 24 hours before the fibrosis process set in. So does that physiologically make sense that the post-ligation syndrome is going to be lesser in the device closure babies, because the heart is going to be adapting to the some slower rise of the SVR, if there is any, in the first 24 hours? Is that been your experience?
Yes, that is 100% been our experience. It's not to say that the device closure, which we implant through femoral venous axis and use echocardiography to guide us, doesn't have babies who have low cardiac output. But basically the natural theory is this, right? Term babies physiologically and slowly close their PDA over the first 3 days and anatomically close their PDA by 14 days. Preterm babies, depending on the gestational age, will slowly close their PDA over either 4 weeks to 8 days, from 26 weeks to 32 weeks. With medical therapy, it augments a physiological slow closure of the PDA with changing loading conditions that can be handled. PDA ligation is abrupt closure. Device closure, some babies have complete loss of flow through the PDA. If everybody looks at my hands, it's a mesh, and basically there's flow, and over the first 24 hours, the mesh closes down, but you may see some of the mesh close down early. And in our experience, we have found that there's less changes in loading conditions and less insults on the pulmonary vasculature and the respiratory phenotype. However, if you're smaller, if you're younger, if you are on inotropic or high respiratory support beforehand, there are still some babies who have abnormal responses to closing the PDA. What we have done, though, in a study that was just published in the Journal of American Heart Association, is we compared outcomes, multi-center, between infants who underwent PDA ligation and infants who underwent device closure. What we clearly showed is that there is less necrotizing enterocolitis, less acute kidney injury, less retinopathy of prematurity. There is shorter hospital stays. Some of the costs are a little bit different in the children who have their PDA closed by a device. And as everybody on this call knows, when you need a ligation, there's also the risk of nerve issues, the vocal cords and the diaphragm. There is the surgery where you're doing single lung ventilation. There is the stress response. So the other thing that we do with our PDA device closures is we keep them intubated, usually for at least 1 day after the device. We give them a little low dose fentanyl to minimize any pulmonary vasoconstriction. And that approach has really led to a significant drop in how many babies we see with low cardiac output. So you are 100% correct that the data shows there is less of a post-ligation impact.
There are lots of questions, because obviously your talk have been such a motivating for the people to ask many questions. I'm not sure, Manoj, how much time we have, but Samir will take up the next session on about the fluid element of it. But how are we with the time front? Because there are a lot more questions still there, because there's been a lot of interest,
As we were discussing at the beginning, it's going to be a real challenge. So how much can we go on for another 5 more minutes, Professor Levy?
Sure, let's do 5 more minutes. This is a very good session.
I'm sorry to keep you from your morning routine. Yeah, please go ahead, Samir.
So I'll take up the opportunity to encroach upon those 5 minutes left with me. Sir, traditionally we have been taught that all the preterm babies, all the chambers of the heart has an additional outlet. So in all preterm babies, when they go in shock, what's your take on fluid challenge? So shall we give fluid bolus as a regular routine? Shall we use only during septic shock, which is vasodilatory shock? Or shall we try fluid challenge for a couple of times, something like around 10 or maybe max 20 ml per kg, and then start inotrope? So what's your take on, sir, fluid challenge, especially in preterm babies who are less than 32 weeks of gestation?
Yes, it's a wonderful question. So to put it in context, there is, the theory that especially in the babies who come out, let's say the 27-weeker who's 800 grams, who comes out and is in just this state of shock, say there is a maternal infection, and you're very nervous to give fluid resuscitation because we know that it could significantly impact cerebral autoregulation or dysregulation. And there are studies that have shown that multiple fluid boluses can lead to severe intraventricular hemorrhage, so forth and so on. However, outside of that early period, I am a big believer in the physical examination. So if you are in a state of shock and you are maybe in compensated shock and you may be warm to the touch distally, I think a judicious approach to fluid resuscitation is completely appropriate. What I will do is I live my life in 3. So I will give normal saline bolus, or if there's blood available, no more than 3 times. So I'll give it 10 ml per kilo of normal saline bolus, but no more than 3 times. If I don't see an impact on it, and I don't push it, I won't do it rapidly. I'll do it over 30 minutes. If I don't see a rapid response, or I see a response to the blood pressure and then it falls back down, then I know that it's likely on to stage 2 and stage 3, which is assessment of contractility and assessment of afterload, and trying to understand which medication or inotrope or cardiotropic medication is the most appropriate. But I think in general, that law of 3 allows you the leeway to safely provide fluid resuscitation in a shock-like state in order to prevent a total collapse. I have unfortunately seen people not give fluid and just rush towards giving inotropy. And I'll give you an example. After, for example, necrotizing enterocolitis or severe abdominal surgery, well, those children are third spacing. Those children are living in hypovolemic shock. And if you just give them inotropic support, they won't have any fluid in their system. They will not be able to supply the systemic circulation. They will build up acid levels, and that will lead to just a whole disaster of problems. So I think it's a safe bet in most children to start with preload resuscitation.
Great, sir. Over to you, Sony sir. If there is anything left, that's end of questions from my side.
As I said, there are a variety of questions. Some of them have been answered in a different way. I don't think we have a time to go through the different indices of on echocardiography about the cardiac function, because you summarized to some extent, and that is a talk in itself about the echocardiography and cardiac functions. So I think majority of your questions have been answered, but there's one very interesting question which is a nice take. I thought it is a very small one, is that when we are looking at the blood pressure, there's an invasive and a non-invasive blood pressure, and how do you take that into account? Which one do you take with a bit more? Obviously, non-invasive you take it with a pinch of salt. So do you just rely on the readings of the non-invasive blood pressure, or I guess in your setup you may use the other integrated monitoring you have in place? And I think with that question we will be able to hand over back to Manoj to close the session.
That's a great question. I'll answer it in a few ways. The beauty of neonatology is we get to pick and choose what we want to do. So the joke is we take the blood pressure that looks better. But honestly, if I have an arterial line or an umbilical arterial line and it's an invasive blood pressure, I think we very much rely on that. Now, you have to understand where the blood pressure is coming from. Is it before the duct, after the duct? Is it and then obviously using the non-invasive blood pressures. We are constantly working to develop other measures of cardiac output. We're really just trying to use these blood pressures as surrogates. We know that they're not the best. So I've been working with people like William de Bood in the Netherlands. We will use NIRS monitoring. We'll use non-invasive cardiac output monitoring. But the long or the short is I feel very comfortable if all I was able to use was non-invasive systolic and diastolic blood pressures, that gets you almost all the way home, 85 to 90%. Our PDA babies, we used to put an arterial catheter in all of them. We actually do not anymore. We just use the combination of, again, systolic blood pressure as a measure of function and contractility, and diastolic blood pressure as a measure of SVR afterload. We try and keep the mean airway pressure, the mean arterial blood pressure in a range that's acceptable. But as everyone knows, that data beyond 7 days of age is really not that accurate. And rather than using one measure, the mean arterial blood pressure, I advocate for using a combination of systolic and diastolic blood pressure. And the take home, if you take home anything from this entire talk, it's don't rely on one measure, understand the mechanism and the disease, and use all of the tools around you to make an informed decision about the overall cardiovascular health of the baby. So I think with that, I just really want to say thank you for the opportunity kind of to spend these few hours with this entire group. And I look forward to hopefully seeing as many people in person once this pandemic goes away.
Thank you, Professor Levy. Thank you. It was a pleasure to moderate the session.
Thank you, sir. It's an honor.
Over to you, Manoj.
So before proposing the vote of thanks to the faculty legend of the day, Professor Philip Levy, and the great moderators, Dr. N.B. Soni and Sami Sheikh, may I request Dr. Naveen Bajaj, the president of the Neonatology chapter of the Indian Academy of Pediatrics, to speak a few words. He's here with us. Over to you, Naveen.
Yeah, good evening, everyone, and good morning, and hello, Professor Philip. It was a continuous 2 hours teaching, and being a neonatologist, I'll have a confession that this is a hemodynamics, and choosing inotrope is probably one of the most difficult and confusing topic. And your 2 hours of discussion as well as the lecture, you have tried to simplify it, and we have gained a lot from your lecture, your slides, and that beautiful table you have put it. And you said take a screenshot, and I did that. And probably I'll take out some time to read it completely, even the one word which you have written, even the footnote below are very useful. And I am sure all of us in India, as well as there are many delegates from abroad, from other countries, has benefited from you. And we are looking forward to seeing you physically, personally, during the upcoming IIP NeoCon. And we have another 4 months to go, Manoj.
3 months to go. 3 months, exactly 3 months.
We will be doing it in May, and it is going to be a beautiful weather, especially in Kerala at that time. Thank you, Professor Philip.
Thank you, Naveen. I can't agree with you more that we had requested for 1 hour of time from Professor Levy, and it's almost going to be 2 hours, and then we were all spellbound by his lecture. I have noticed this, like he talks and his talks are like this, starts in a very humble way, and then it takes to a level where, your thinking opens up to greater and greater heights. Thank you so much, Professor Levy, for taking time to be with us today. And as Dr. Naveen was saying, we Hope to see you in person, at least virtually, for our national conference. Let's hope that international travel ease up by then, and then let's hope to have. So we hope to have you hear more and more from you. Thank you so much, sir.
Thank you.
Thank you, guys. Have a great day. And
Thank
good
you.
night.
Thank
Good,
you.
good night. I also would like to thank two great moderators who did the difficult task of navigating through the volley of questions and trying to pick out and then keep the session very, very crisp in whatever way they could. And let me personally thank Dr. Soni. He is himself a neonatal hemodynamics man, and Dr. Samik Sheikh, very familiar to all of us in India. So let me thank both of you for gracefully moderating this session. Thank you so much.
Thank you.
Before I close this session, I would thank all of you, dear delegates. You have been with us for almost now nearing 2 years. We are completing 2 years by May, and we'll be completing 2 years in this series. It's a true honor to have you all with us. And in the upcoming session, the next session is going to be another legend who has done original work in non-invasive ventilation, Professor Corrado Moretti, the current president of the Union of European Perinatal and Neonatal Societies from Italy. So he will be talking to us about non-invasive ventilation strategies, the current update. That is going to be on 10th February at the same time. Until then, goodbye. Thank you.
Thank you, sir.
Thank you. Thank you. Thank you, everyone.